Hello, I'm hematologist oncologist Dr. Tony Talebi. Today we're going to discuss an allogeneic stem cell transplant. I have the pleasure of being with Dr. Denise Pereira, Assistant Professor of Medicine at the University of Miami and Chief of the Bone Marrow Transplant Unit. Thank you for being here.
Thank you for having me here.
Dr. Pereira, what is an allogeneic stem cell transplant?
So an allogeneic stem cell transplantation is indeed a transplant that you use a donor as the one who will provide the stem cells that would eventually repopulate the patient bone marrow.
So how is an allo transplant different from an auto transplant versus an umbilical transplant?
So the major differences indeed between autologous and allogeneic stem cell transplantation. On autologous stem cell transplantation, you use the patient own stem cells. Usually in that case, the patient bone marrow have not been severely involved by the disease. On the other hand, whenever you have an illness that tends to affect significantly the bone marrow, not so infrequently, we tend to prefer the use of allogeneic stem cell transplantation. Now, the allogeneic stem cell transplantation is actually a general category that means you have a donor that is not the own patient for the stem cells. That in itself can be actually divided in subsequent categories, including related donor, when you have a sibling or someone else within the same family that will function as a donor of the stem cells. The second category would be you have an unrelated donor, when we have an adult that would be unrelated to the patient that would be the source for the stem cells. And finally, a cord blood stem cell transplantation, when the actual source of the stem cells are the cord blood. They all, if I might add, they all within the category of allogeneic stem cell transplantation.
So what is a stem cell to start out with?
So a stem cell is a very undifferentiated cell that can indeed turn into different tissues. Now, there are some stem cells that are so undifferentiated they can indeed pretty much turn into anything. But on our particular case, what we are most interested on are the hematopoietic stem cells, the ones that can give birth to regular red cells, white cells, and platelets.
So why is an allogeneic stem cell transplant done in the first place? What's the reason for it?
So there are different indications for that, and in fact it varies depending on the disease. But the primary thing is whenever you have a disease that patient will have a better survival with the allogeneic stem cell transplantation over regular standard chemotherapy, that's when we will offer a patient an allogeneic stem cell transplantation.
Mm-hmm. Do the actual donor stem cells, do they help in fighting the disease as well?
So that is quite interesting, because different than autologous stem cell transplantation, when all the work for the cure of the cancer is done by the chemotherapy, on patients with allogeneic stem cell transplantation, we know in fact that the donor immune system play an important role in helping us to fight the cancer.
And that's what we call the graft versus tumor effect?
Correct.
How effective is that?
You know, it varies from disease to disease. In all fairness, this was first established with CML, but we also know that the graft versus host disease is also very important. Graft versus tumor effect is very important for AMLs, and to a less likelihood to also ALLs. It's also known that in certain forms of lymphoma, graft versus tumor effect is rather prominent.
I see. So this is such a serious procedure. How do you know if a patient is an ideal candidate to even tolerate the procedure?
So that is a very good question, and that has actually changed over time. But there are, once again, two things that we keep in mind. Number one, patients who tend to do better are patients who have their disease under control, because this is associated not only with better results, but also with a lesser chance of one dying from the procedure itself. The other thing that is very important is to make sure that the patient have overall organ function that would allow them to tolerate the procedure. And for that reason, the patient will always undergo a pre-screening test that will confirm that the patient can tolerate the therapy that is being proposed. Those screening tests include not only your general blood work, but also specific tests that will look into your heart, your lung function, your kidney function, so on and so forth, once again to assure that we can safely pursue the treatment.
So how do you go about finding another human being that can potentially donate stem cells to a patient?
So we do test what we call HLA genes, and the testing is a simple blood test. It can also be done for screening purpose on the oral mucosa. But if, in all fairness, for final decision, we always do blood test, and we initially look within the family. We look within the siblings. Basically, the reason why we do that is because one individual HLA is inherited half from the mother and half from the father. Therefore, the other individuals that would be more likely to have inherited a very similar genetic pose would be the patient's siblings. To each siblings, there is approximately a 25% chance of them being a match. If so happen that the patient has no match within their siblings, we then go into the National Marrow Donor Program, where we have millions of potential donors register for as a stem cell source.
I know parents always ask us, close family members always ask whether they can be donors. Why is that not the case?
Yeah, it is a mathematical reason. Basically, the likelihood of having someone with the same HLA match is 1 in hundreds of thousands. Therefore, unless you have inherited the same genetic pool, namely from the same mother and same father, the odds that one will be a match, even within the same family, even being a half sibling, would be extremely low and time consuming. Therefore, if we do not have a match within full siblings, as a general rule, and again, short of rare exceptions, we would move on to looking into potential donor within the National Marrow Donor Program. The other option that we now have available is the use of stem cell cord bloods as a potential source of stem cells.
Okay, so why is it more common for Caucasians to be able to find a match, at least in the United States?
So that is a very good question. It's close to our heart because here at Miami we have people from multiple backgrounds, and unfortunately at times we are unable to find donors for a number of patients. There are two major reasons why this happened. Number one is because there are more Caucasians in the registry. Therefore, you have more people to screen and a higher chance to find a donor. The second reason why you also have lesser of a chance to find a donor if you are, say, African American, is because there is a larger number of HLA there segregated to this patient population, making it even harder to find a match.
I see. Well, let's talk about the HLA itself. There's HLA A, B, and C, and DR. Would you please explain what that is and what you look for?
So HLA are genes. They are segregated to chromosome 6. They are associated with a number of different immune functions, and they have been known for many years, actually more than a few decades. They are closely related with rejection of organ as also hematopoietic stem cell transplant.
Is it preferable to have stem cells from a family member or a non-family member?
As a general rule, it's preferable to have, as a donor, a family member, because the chance of graft-versus-host, which I realize we'll be talking pretty soon, is lesser if you have a family donor.
So now that you mentioned it, just please explain, what is graft-versus-host?
So graft-versus-host is nothing less than the graft that have been provided to our patient, creating a rejection toward the patient's own body. Now, the way that I usually try to explain this to the patients is that once you have your immune system, it gets used to it, and it learns to recognize your body as its own. Once this immune system, though, is transferred to someone else, depending on the degree of the match, and even at times when you have a perfect match, some minor abnormalities might trigger this response. That is when, again, the donor cells do not recognize the recipient or patient cells as its own. And then with that, a whole process of rejection starts. This can be manifested in different ways, which would include more acutely with changes in as a skin rash, changes in liver function tests, as also changes associated with the gastrointestinal tract, namely a lot of diarrhea and nausea, but also can modify as time go on, and it can affect many different areas of the body, including eyes, mouth, lungs, etc.
Okay, well, we'll come back to that. All right, so how are the stem cells collected?
So it depends what will be the source of the stem cell. If you do peripheral blood, it's relatively simple. A donor will receive an agent that will help to mobilize the stem cells that usually reside on the bone marrow and circulate on your blood. This medication is given once a day for 5 days in a row, and it's called filgrastim. And once we get to the 5th day, the donor's blood is actually filtered, and the fraction of that particular fraction of cells is removed. The other option would be if you do a bone marrow harvest. The bone marrow is done with the donor under general anesthesia, and we have them multiple bone marrow aspirates being performed on each side of the hip bones. And once you have enough cells, we can interrupt the procedure. We can complete the procedure.
How can one become a donor? What process do you have to go through?
So what we have now is the ability for anyone who wishes to list themselves as a potential donor through the National Marrow Donor Program. We advise the donors who are serious about that and know they will be willing to respond once called to go to the nearest blood bank and just inform them that they would be like to be on the National Marrow Donor Program on the registry. And once again, this can be done into the closest blood bank to your home.
Is a donor potentially reimbursed financially for this, or?
No, that is also a good question. As of now, there is no financial incentive for the donor.
I see. All right, so now let's say a patient has had, a donor has been found, stem cells have been collected, now they get admitted to the hospital. What happens next?
So once the patient is admitted, the first step is to provide the chemotherapy. The chemotherapy is provided for 2 different reasons. Number one is to, in fact, improve further the disease control. The second reason, though, is to immunosuppress the donor enough to a way that would allow the stem cells to engraft and to grow into the recipient patient bone marrow.
I know this generally takes a few days on average. Can the patient expect any side effects during this time?
Yeah, so the chemotherapy, as you very well mentioned, take a few days. The most common side effects that one sees is the regular side effect that you expect with chemotherapy: nausea, vomiting, those few days. Evidently, as time went on, patient will have other side effects associated with it. But even before we see many of those, the patient will be given an infusion of the donor stem cells. At around that time, one must start an immunosuppression medication that would allow the donor cells to settle in without much of a reaction. Once the cells are infused, we then expect that there will still be a decline on the number of cells on the blood, namely your patient will become thrombocytopenic, which means that the platelets will go down, the white counts will go down, so also will the red cells. Once, though, the patient, the donor stem cells start to engraft, we see that over a few days, those counts start to improve steadily.
I have seen some patients develop mucositis. Would you please explain what that is and how do you handle it?
So mucositis in this particular situation is caused primarily by the chemotherapy that we use to prepare the patient to receive, but also by another chemotherapy that is called methotrexate that we commonly use to prevent the rejection of the stem cells. And what it means is that is an inflammation and in fact a peeling of the most superficial layer of the patient's mouth, esophagus, and gastrointestinal tract. And this is associated with symptoms that are very characteristic, namely difficulty swallowing, sores in the patient's mouth, and diarrhea.
I see. You know, sometimes you guys like to use very high doses of chemotherapy called myeloablative, and sometimes you use middle-of-the-road non-myeloablative chemotherapy doses. When do you choose and why?
This is something that is a relatively new development, if you can call 10 years, recent development. But in all fairness, it depends on the patient overall health, on the patient age, and also on the disease. As a general rule, there is association with improvement in disease control with higher doses of chemotherapy. Having said that, there is also a clear-cut relationship of complication with the higher doses of chemotherapy than the ones that will be lower. We primarily tend to use reduced intensity conditioning regimens for patients who are older or who have other comorbidities.
So how are the stem cells transplanted back, and why is there a risk of an allergic reaction during this procedure?
So the stem cell is given back as an intravenous transfusion, as we have seen in, with platelets and red cells. The risk of a reaction is dependent on a few things, including the patient and donor blood type, but also on the fact that the patient might develop over time some antibodies against leukocytes that might be on the product that is infused.
I see. Okay, so let's say now that the stem cells have been transplanted back. What happens next? What should the patient expect in the next coming days?
So once the stem cells have been transplanted back, we make sure that the patient is immunosuppressed enough to once again accept the cells. And also we know to expect to see a more florid side effects from the chemotherapy. In all fairness, when you transplant stem cells, those cells are very young still, and they have to find their way into the patient's blood to their bone marrow and then grow. For those days that this is happening, one can see an exacerbation of the chemotherapy that has already been given. And the most common side effects that one would expect to see is the so-called mucositis, as we have discussed, with sores in the patient mouth, difficult swallowing, and also diarrhea. The other thing that we know to expect is a significant drop on the blood counts that will ultimately lead, in all likelihood, to red cell transfusions, as also platelet transfusions, and finally a drop on the patient white count that would make the patient for sure more susceptible to infections. And that is indeed the time that we expect to see patients developing infections that would manifest itself mostly by fevers.
So how long does it typically take for the stem cells to take and for the marrow to start producing cells?
As a general rule, it will take between 10 to 14 days if you use peripheral blood as a source of the stem cells. If you do use bone marrow, it takes longer. Average time nowadays between 14 to 18 days, provided that you're using growth factors, namely filgrastim, to help to speed it up the engraftment time.
I see. So let's say now that the stem cells have been grafted and now they're starting to grow, and let's talk about graft versus host again. Would you please explain what that is again and how does that happen?
Yeah, graft versus host is induced by the donor immune system cells, and this is basically happen because the donor stem cell, the donor immune system is used to live within the donor body for whatever number of years the donor has. Once those cells are then transferred to the recipient, namely to the patient, you would expect that some cells might not fully recognize that body as its own. And for that reason, a process might be triggered that ultimately can lead to injury of certain organs on the donor. On the recipient.
So graft versus host used to be classified as acute versus chronic, but I understand that's changed in your world. Why is that?
Yeah, it has changed because we used to say that up to 3 months would be acute graft versus host, and past 3 months from the transplant would be classified as chronic. There are indeed symptoms that are clearly associated with a more acute form, which is a skin rash, diarrhea, and liver abnormalities, and there's a whole other array of symptoms that are more classically associated with chronic graft versus host. But having said that, there is just so much overlap, and also the fact that we used to use the date of transplant to make the cutoff has just not found to be accurate associated with the clinical presentation. So that's why the classification has changed.
So you said that you like to start immunosuppressants even before the transplant is done. How long do you maintain the patient on immunosuppressants, assuming nothing goes wrong?
So the immunosuppression under our protocol, we started the day before the stem cells are infused, and as a general rule, you tend to give the immunosuppression for approximately 6 months, provided the patient tolerates and no significant graft versus host develops.
I see. So now let's say, God forbid, the patient does develop significant graft versus host a few days into the transplant. How do you treat that?
So the way to treat graft versus host is basically by increasing the immunosuppression, and you can use a whole number of different drugs to try to reach the goal.
I see. So that leads us into the other section, which is infections. CMV is a very important virus in your specialty. Please explain why that is.
So CMV, now well known as CMV virus, used to be responsible for a pneumonia that was very common in patients with stem cells. Once we understood that this virus was the one that caused the pneumonia, we were able to treat, and actually nowadays even to prevent most of those instances. Also, CMV can be associated in our patient population with diarrhea and other complications. The CMV status, namely if the patient and the donor are positive or negative, are also very important considerations when you're monitoring the patient for a possible CMV infection.
Mm-hmm. So CMV is a virus that lives in harmony in many human beings around the world. Why does it cause so many problems in transplanted patients?
Because in fact, on patients who have who are indeed immunosuppressed, the virus tend to have the ability to become active and cause problems.
I see. So when do you start checking to see whether the CMV is being reactivated in the blood?
Once the patient receives the allogeneic stem cell transplantation, we do tend to check at least once a week for the presence of what we call CMV viremia, which is not necessarily the presence for the CMV disease.
So if you do see the levels going up, what do you do about it?
So over time, once we were able to identify CMV as responsible for, once again, many complications, namely the pneumonia that we have, the interstitial pneumonia that we have discussed, is also diarrhea, we learn also how to monitor the levels of the CMV in the blood. And it is clearly the increase in levels of the CMV in the blood is clearly associated with future development of pneumonia, as also diarrhea as discussed. Once we see that the patient levels are increasing, we can do what we call preemptive therapy, which is we can start the treatment for CMV with an antivirus even before the patient develops any symptoms from it.
I see. And what if, God forbid, the patient does develop active CMV infection? Is the treatment different in that scenario?
So the treatment is somehow different. It does consist of use of an antiviral therapy, but under certain circumstances, one can also use gamma globulin to improve, expedite the response and to improve clinical outcomes.
What about other infections? You know, fungal infections are not uncommon. How do you diagnose and handle that situation?
So fungal infections are not uncommon in patients who are immunosuppressed. It is certainly a concern on our patient population. Different facilities will have different protocols of how to monitor and to prevent those. But as a general rule, on transplant patients, we will give prophylactic antifungal medication and will then monitor patients closely for symptoms. There are other centers who will use certain blood tests also to monitor for fungal infection.
What if the patient has young children? When can they see them?
So on the acute phase, that means when the patient is admitted, we do not allow visitor of young children. But having said that, once the patient is discharged, because it's felt to be safe for the patient to return home, we do not require them to stay away from their kids.
And what should the family expect during the time that the patient's in the hospital? What should they do?
You know, I think the most important thing is the family should remain supportive, should help us with reinforcing the patient to the patient what are the things that are needed to be done, namely, you know, the oral care, to take its medication, to try to reach to the extent that is possible, and also to be attentive to you know, some rules that we will advise the patient and the family to follow, namely some dietary restrictions and a restriction with contact with people who are sick, if you will.
I see. All right. An allotransplant is one of the most serious procedures a human being can undergo, in my opinion. What are some potential long-term complications of an allotransplant?
So first, I would like to make sure that we disclaim that not all patients will be cured by an allotransplant, and therefore, unfortunately, relapse, that means the recurrence of disease, remains a problem. But if the patient is cured, there are things that one can encounter and then can in fact affect significantly their quality of life. The two most common things that I think are worth mentioning are the continued chance of you occurring an infection. This tends though to diminish as the patient gets off the immunosuppression as also as time go on. The second thing that we see as a significant complication is all things related to graft-versus-host, mostly then in a chronic form, and those things would be some thickening of the skin, some skin rash, difficulty with moving their arms and legs, issues with stiffness on their joints, problems associated with dry eyes, dry mouth, and in some patients really issues with the ability to breathe.
As you know, when the patients have been in the hospital for several weeks, they want to go home so bad. When is it safe for them to go home?
So we tell the patients that they can go home once their white cells have recovered to what we would consider a safe level. We also cannot have any active ongoing infection, and we also have to have a patient that can not only drink and eat some, but also who can do some basic IDLs, basic function at home, like walking, going to the kitchen, going to the restroom, etc.
So you mentioned relapse. Let's say someone has had leukemia and now they've had an allo transplant, and you notice that leukemia is coming back. What are some maneuvers that you can play with?
So there are a few options in cases like that. One would be to, if the patient remains still on immunosuppression, would be to remove the immunosuppression to provide an opportunity for the donor immune system that has been transplanted to react against and kill the cancer cells. The other option that one have is to reinforce the donor immune system by additional infusion of donor stem cells. Donor T cells.
As you know, what patients want from us the most is hope. How do you give your patients hope when we need an allo transplant?
So I always tell them that the first time that I heard about an allogeneic stem cell transplantation, I was probably on my teens, and I remember we would not do this on patients much older than 30. By the time that I got to be a fellow, the old ones in my ward, on my transplant ward, were 50 years old. And now we routinely do patients here up to the age of 70. The reason why we do that is because we've been able, over the years, to do the procedure more safely, and we fortunately can now offer the choice, the opportunity to be cured to a much larger number of patients than we did even 10 to 20 years ago.
You truly are part of a very fascinating field. Thank you so much for being here.
Thank you for having me here.
Thank you for watching. We hope this has been educational for you.